chromosome, and in this case of extreme lionization, 1X chromosome is inactivated. So hemophilia A and B can also be acquired, maybe due to autoimmune diseases, pregnancy, and sometimes idiopathic causes. In hemophilia, these are the following signs and symptoms. The bleeding in the joints can cause swelling and pain or tightness in the joint. This affects the knees, elbows, and ankles. There is bleeding in the skin or bruising or bleeding in the muscle and tissue that causing a deposition of blood in the area called hematoma. Other signs or symptoms including bleeding of the mouth and gums and bleeding that is hard to stop after losing a tooth. Also, there's bleeding after circumcision, bleeding after having shots such as vaccination, and bleeding in the head of an infant after a difficult delivery or cephalohematomas. So these are the clinical picture of what's happening. So, so in this, the patient demonstrated bleeding in the joint and also bleeding in the gums and mouth. So other clinical manifestation, there is blood are present in urine and stool, and patient experience frequent and hard to stop nosebleeds. So prognosis, so basically the prognosis is that debilitating and progressive musculoskeletal lesions and deformities and neurologic deficiencies. So while acute hemarthrosis causes extreme pain and temporary disability, there, chronic joint bleeding, other than causes pain, sometimes leads to patients not being able to walk. So inflammation and eventual permanent loss of mobility. Bleeding into muscle tissues may cause nerve compression injury, which leads to disability. The bleeding in the head, sometimes in the brain, can cause continuing problems such as seizures, paralysis, loss of memory, coma, and sometimes can be fatal as death. The bleeding started instantaneously after triggering event or may become manifest after a delay of several hours. Some bleeding are spontaneous. And lastly, death can occur if there is no cessation of bleeding or bleeding occurs in vital organs such as the brain. So basically, family history is one of the records that is important in investigating the bleeding. Nowadays, people who have had a family member with hemophilia are asked that their baby boy will be tested soon after birth. A blood sample drawn from the umbilical cord are drawn immediately after the baby is born. Umbilical cord is better at finding low levels of factor 8 than factor 9. So because factor 9 takes time to develop, at least 6 months of age to normal levels. So a mildly low level of factor 9 at birth does not equate that the baby has hemophilia B, and a repeat test when the baby is older is necessary. So in newborns without family history of hemophilia, hemophilia suspicion is raised when the newborn exhibits bleeding after circumcision, after drawing blood and heel sticks, in the head after delivery, or after using special devices or instruments. Also, it is suspected when newborn has unusual raised bruises or large numbers of bruises. Screening tests. In laboratory diagnosing hemophilia, there are steps. In screening tests, the patients with hemophilia usually has a normal blood or normal complete blood count. However, when there is a unusual heavy bleeding or long-term bleeding, the patient's hemoglobin and red blood cell count lowers. The activated partial thromboplastin time is abnormal, while the prothrombin time are normal, since the APTT measures factors 8, 9, 11, and 12. Thrombin time and fibrinogen tests are also normal. Clotting factor tests are confirmatory tests to diagnose a bleeding disorder. So this assay helps in showing the type of hemophilia and the severity of hemophilia, since knowing the type and severity of the disease aids in creating the best treatment plan for the patient. So, so these are the reagent that is used. So 100 microliter of PTT reagent plus 100 microliter of patient platelet poor plasma dilution, and another 100 microliter of factor 8 depleted or deficient plasma mixture, or a factor 9 depleted mixture will be used in clotting factor tests, incubated so that and measured. measure the clotting activity. So in this chart, as we know, severe hemophilia has a less than 1% of factor 8 or factor 9 activity. A moderate hemophilia case has 1 to 5% factor 8 or factor 9 activity, while a mild case of hemophilia has 6 to 30 factor 8 or factor 9 activity. So prevention, the best way to treat hemophilia is to replace clotting blood factor so that the blood can clot properly. So this is the primary motivation or goal in treating hemophilia. So this is done by injecting treatment products called clotting factor concentrates into a patient's vein. So there are two main types of clotting factor concentrates. First is these are the plasma-derived factor concentrates and recombinant factor concentrates. So plasma-derived factor concentrates are prepared from healthy plasma donors using chemical fractionation, and after these are processed using immunoaffinity columns, pasteurization, and the addition of solvent detergent. The concentrates will also undergo viral inactivation. And another clotting factor concentrate is the recombinant factor concentrate, which are prepared by genetic engineering using DNA technology. These recombinant factor concentrates also undergoes treatment to remove blood-borne viruses. So other products in the intervention against hemophilia are Hemlibra, which replaces the function of factor 8. Another name for the Hemlibra or generic name is the Emicizumab. Then another treatment is the DDA-VP, or Stimate or desmopressin acetate, which are used for mild and moderate or mild to moderate hemophilia cases. The function of this treatment is to release factor 8 from where it is stored in the body tissues. Another one is the Amicar or the epsilon aminocaproic acid, which prevents blood clots from breaking down, which and results to a firmer clot. And lastly, our cryoprecipitate, which are substances comes from thawing fresh frozen plasma, but is now seldom used because factor 8 level in this product decreases by 50% on the fifth day. So traditional replacement therapy for hemophilia requires twice or thrice weekly intravenous infusions of factors, which is costly in the long run. Nowadays, gene therapy has been studied as an option in treating hemophilia using non-integrating recombinant adeno-associated viral vectors. This can provide long-lasting clotting factor replacement and used to induce immune tolerance. However, the presence of pre-existing neutralizing antibodies to the AAV capsid causes problems as seen on potential participants. So another prevention is that detection of hemophilia carriers is useful in prediction of symptoms and prenatal counseling. One cost-effective approach is to measure the ratio of factor 8 activity to von Willebrand factor antigen ratio in order to predict carrier status. Other than this approach, the woman can be tested for the common intron 22 inversion or get whole exosome sequencing. This method provides an extremely likelihood of detection. So hemophilia A and factor 8 inhibitors, these are suspected when there is a persistence of bleeding or even after an appropriately dosed concentrate administration. So the level of factor 8 activity does not increase to target levels. So even if the patient is given a clotting factor like plasma-derived factor recombinant, however, the level of plasma 8 factor 8 activity does not seem to increase or get well. So factor 8 inhibitors are suspected. So in detection of factor 8 inhibitors, this is usually done by using one-stage clot-based factor 8 assay. A factor 8 of more than 30 units per deciliter is the normal one. So less than that is suspicious. So another step is to do mixing studies in which factor 8 from the normal plasma is partially neutralized and the mixture's PTT remains prolonged or uncorrected. Then last one is the an assay called Nishmigen Bethesda assay, which helps in quantitating the inhibitor. So low responders have a less than 5 NBU or Nijmegen Bethesda assay unit, while high responders have more than 5 NBU. So low responders in this case requires large doses of factor VIII concentrates, while high responders needs activated PCC, and that should not exceed 200 units per kilogram per day and must be distributed in 2 to 4 injections. Another treatment for those high responders are Novo 7. This bypasses the physiologic factor VIII replacement and promotes thrombin formation. So another drug is the imicizumab, which which mimics the factor VIII activity, so that the coagulation cascade can go activate tennis complex and so forth. So in my journal review, I have a case study here in which a 90-year-old male with a past medical history of hypertension, chronic kidney disease, stage 2, and hyperlipidemia presented with complaints of intermittent hematuria. The patient has no prior history of hematuria or mucosal bleeds and does not have trauma. He did not have a significant medical issues in his family. Family history was negative for any cancers or bleeding disorders. Physical examination was unremarkable for any acute findings. So the patient started bleeding from the right arm where he had intravenous line that had been placed earlier. So here is the case presentation or the laboratory results of the patient. So in this case, APTT has a high result, 48.4. The factor VIII activity is less than 3, which is far from the reference value of 50 to 150. And the factor VIII inhibitor is 12, which supposedly to be negative. So this is the summary of the patient. So patient was, because the case is quite long, but this is the summary. So the patient was given corticosteroids and methylprednisolone so that it can combat the inhibitors, and simultaneously started on recombinant porcine factor VIII intravenously. So hematuria and arm bleeding subsided after the recombinant porcine factor VIII was given. The factor VIII assay came back at 258%. So the patient was discharged, but returned 5 days later due to recurrent of hematuria. Factor VIII assay at 140. The patient was tested with that. So another factor assay the tested was done again, and this time it's below, it's 9%, quite decreased. So factor VIII inhibitors were checked again, and again it's 12 Bethesda unit per ml. So the patient was then started with recombinant factor activate or recombinant activated factor 7 as a bypassing agent, and this is repeated every 3 hours. The hemostasis was achieved at 24 hours, and patient does not exhibit recurrent hematuria at 48 hours and discharge. So in this case, as we try to diagnose the patient, the patient has no family history of bleeding disorders. The factor VIII activity is decreased. There is factor VIII inhibitor, APTT is increased. So the diagnosis for that is that the patient has acquired hemophilia A. So this is a rare disorder caused by neutralizing autoantibodies or inhibitors against clotting factor VIII. This occurs in both male and female without previous or with no previous bleeding history. So most of these cases are idiopathic, and the incidences are associated with pregnancy and with old age, more than 60 years old. So in a journal review by Andrea Stade et al., the titled International Recommendations on the Diagnosis and Treatment of Acquired Hemophilia, in these papers, the authors has come up with a recommendation on the diagnosis and treatment of acquired hemophilia A based upon independent review on the 2009 International AHA recommendations and identification of areas that required improvement. So the feedback of these researchers were compiled in a single document, and the current available published evidence was assessed. So the authors used a grading system according to Guyot et al. So grade 1, these are for recommendations, which has a clear impact on patient safety, and the benefit outweighs the risk and burden. So further, the grade 1 is divided between 1B and 1C, in which 1B is data-supported statement, while 1C are evidence unsupported recommendations, but still appeared important for patient safety and benefit. So another grade is the grade two, in which these are for weaker suggestions and may change when there's availability of novel data. So further, this grade is further divided into 2B and 2C, in which 2B has with support from registries or studies, and 2C has with support from has no support from registries or studies. So the researchers recommend that the diagnosis of AHA should be considered whenever an acute recent onset of bleeding is accompanied or unexplained EPTT recommended prolongation. Um, they also recommend confirming a diagnosis of AHA by testing factor VIII activity and inhibitor concentration using the Bethesda assay and or an anti-factor VIII ELISA. And they also recommend anti-porcine inhibitors using a modified Bethesda assay. So, so this is their chart. So when there is an isolated prolonged APTT, and if there is unexplained patient bleeding, an APTT mixing study is done, and there is a correction in the intrinsic factor deficiency. And if factor VIII is prolonged, so it is likely that AHA is the diagnosis. So they need to confirm this by Bethesda assay or an anti-factor VIII ELISA. So they also has recommendations for hemostatic treatment, such as the use of recombinant activated factor A, factor 7, and the use of prophylactic or bypassing agents, as well as close monitoring of factor 8 activity during therapy with recombinant factor 8. So lastly, they also have an recommendation for inhibitor eradication, such as recommended IST in all patients with AHA, and also thromboprophylaxis according to ASH guidelines. Also, they also recommended to have factor 8C monitoring monthly during the first 6 months, and they don't recommend the use of high dose intravenous immunoglobulins for eradication of inhibitor. So these are my references, and thank you. Hello, hello, ma'am.
All right. Audience first, any question? So the presentation is about
Hemophilia.
two uh two hemophilias, right? So A and B. Okay.
Yes, ma'am.
The topic is all about hemostatic balance, okay, problems. Okay, so we know previously that there should be an equilibrium or a constant, relatively constant balance between the presence of circulating inhibitors and circulating um, clotting factors, right? So in this case, based on the presentation, it depends whether the condition is inherited or acquired.
Yes, ma'am.
Was there any particular report about the age of onset? So immediately after delivery of the neonate, a suspect patient will exhibit bleeding symptoms already. Can
Yes, ma'am.
you clarify? Okay. Can you share with us with regards to the clotting factor 8 and clotting factor 9? How are they produced? Are the levels relatively constant?
Um, Factor 8 are produced by hepatocytes in the liver, and the levels of factor 8 are constantly produced are the levels are constantly produced in levels. Yeah, sorry.
So in your report, you mentioned about the percent activity, right? So
Yes, ma'am.
laboratory diagnosis would measure the amount of the circulating clotting factor, for example, in terms of percent activity, isn't it, Sir Kenneth?
Uh,
The report, the manner of reporting for factor 8 and 9 reported in terms of percent activity.
yes, ma'am. It actually is here. So these are measured through these are in percent activity.
I think it showed a tabulation.
Okay.
There are 3 degrees of severity, and then it showed us. Okay, so the reporting. Okay, so there is actually estimation of factor 8 or factor
Factor
9.
9 activity.
Okay, measured in percent activity. So you have less than 1% for severe.
Yes, ma'am. Less than 1% for severe hemophilia, 1 to 5% for moderate, and 6 to 30 for mild hemophilia.
Is were you able to present also any quantification if there is a need to quantify?
Quantify the level of factor 8.
Yes. Is there any recommendation? You also mentioned about the international expert recommendation on the diagnosis of hemophilia. So was it mentioned also that there is a recommendation to quantify the amount, or only the percentage activity will do?
Only the percentage activity will do, ma'am.
Can you read the question? Sir Alex, okay.
Hello. Sir, can you mention different treatments such as drugs and the transfusion of cryo, precipitate, and even gene therapy? I'm just wondering which is the safest or most recommended of them, and also what are how will a person be a candidate for gene therapy? Thank you.
Regards regards for that, sir, I think the most safest and most recommended is the recombinant factor 7A, active recombinant factor 7A. This is effective since it bypasses factor 8 activity, and this is the safest option since this is genetically engineered and not from pooled human plasma. So, for the question of Miss Yun Yu, if the first child is hemophiliac, so what are the chances of the second child being hemophiliac? The chances with that is 25%, and yes, it gets worse with age since there is spontaneous bleeding. As for a question from Mom Salome, is there any gene therapy that boosts the production of missing clotting factors? It is the adeno the gene therapy I mentioned earlier, the recombinant adenovirus or AAVV vector.
But can you show us, do you have any illustration or picture about the factor 8, factor 9, and the inhibitors to them, inhibitors of factor 8 and factor 9.
Inhibitors of factor 8 and factor 9. I don't have the picture, ma'am.
Okay, so you can just share it next week.
Okay, ma'am.
Now, it would be better if you have some sort of a flow chart showing the interaction between factors 8 and 9 and their corresponding inhibitors, Sir Kenneth. Okay.
Okay, ma'am.
You mentioned about acquired hemophilia. Okay. So
Yes,
is
ma'am.
it only the acquired type that tends to be autoimmune?
Yes, ma'am. It is the acquired type tends to be autoimmune because because as as well as acquired type. Yes, ma'am. Sorry. Yes, ma'am. It's the acquired type that tends to be autoimmune.
How about the inherited type?
Inherited type, it it becomes autoimmune if the patient is constantly being therapy or constantly being treated with factor 8. The body begins to develop immunity against factor 8, and treatment is and succeeding treatment will not be responding, or is not respond the body will not be responding to the successive treatments.
So, can you show us the antigen antibody reaction so that we will understand where does
Okay, ma'am.
autoimmunity comes in? Okay. So just as a simplified illustration, right?
Okay, okay, ma'am.
So okay. Also, you showed us there was a flow chart, rather an algorithm. Okay, one of the consensus. Okay, there. So why is it that lupus anticoagulant is included in the ruling in algorithm? It says there, consider lupus anticoagulant or other inhibitor. Can you elaborate on this? Why is it included in the algorithm?
um
Just take note
um um,
why what is it in the lupus anticoagulant that would make it become part of this particular diagnostic algorithm. Okay, so there should be a some sort of connection why lupus anticoagulant is being considered also. Okay,
okay, ma'am.
and this one, this flow chart is it only applicable for hemophilia A and not for hemophilia B?
This pro chart can, I think, can also be applicable to hemophilia B, only that acquired hemophilia B is less studied compared to acquired hemophilia A, especially since acquired hemophilia B has less cases compared to acquired hemophilia A. But this flow chart can also be used in diagnosing acquired hemophilia B, since they both share similar diagnoses such as prolonged APTT mixing studies, only that their main difference is that um, there needs to be a measure of anti-factor 9 ELISA.
So, but no picture in the guidelines. Only this one.
Yeah, only this one now. Because the study of those researchers focus mainly on acquired hemophilia A.
Right. So, also, we need to know more about immune tolerance that you mentioned. Do you have that slide? Can you show it again?
Immune tolerance. Oh, this one.
What is immune tolerance, by the way?
Immune tolerance is the immune tolerance, ma'am, is the state in which the immune system is unresponsive to substances or tissues that have potential to induce an immune response. So the function of non-integrating recombinant or the AVV vector is that it stimulates immune tolerance.
So, is it some sort of an immune suppression therapy? Right. So, based on what you just said, immune tolerance is when the immune system is not responsive, right?
Yes, it's not
Okay, so there
responsive
is
to
okay, so there
substances.
is a
There's
diminished response of the immune system to any triggering factor, substances, or any molecule. Okay, so that this unresponsiveness will make your immune system not able to produce the corresponding, for example, antibody production, right? Because it's no longer responsive. Correct me if I'm wrong, Sir Kenneth. Right, so gene therapy appears to induce immune unresponsiveness. So can we say that gene therapy is an immunosuppression treatment? So
yes, we can
we
say
look at
that. Okay,
go ahead. Gene therapy, the one that you're mentioning here, gene therapy only applies to acquired hemophilia, sir.
gene ther-
Is it only
Uh,
used for acquired or also for the inherited?
it's also for use for inherited hemophilia, ma'am.
So both hereditary and rather inherited and acquired hemophilias are autoimmune disorders. That's why you need to suppress the immune system. Is that it? Can you check on it, Sir Kenneth?
Okay, ma'am.
Also, were you able to answer the earlier question with regards to the replenishment of the clotting factor? So, based on the cases, okay, or the description of hemophilia A and B, there appears to be diminished activity, okay, of factors 8 and 9. So these are coagulation factors, okay. So is there any replenishment of clotting factors so that they are maintained at a relatively constant level? So if yes, you can probably share with us how they are being replenished, right? So in normal situations, physiologically, right? So it's only when there is injury, for example, to the blood vessel or tissue, when the coagulation factors become activated. So you showed a cascade earlier. Can you show it to us again? The coagulation cascade.
Okay, ma'am. Uh, this one.
Yes. Okay. So this is showing us both the intrinsic, extrinsic, and then you have the common pathway over there in the middle, right? So in in factor 8 deficiency, can you show us what are the coagulation factors that may possibly contribute to the severity of the condition based on this pathway? So which other factors interplay with your factor 8?
Can I include that in the next presentation with your question? I'll just take note. I'll take note of
All
that.
right. Okay. Sir Peter, you're raising your hand.
Good morning, ma'am. Ma'am, can I help Sir Ken answer one of your questions regarding the
Sure.
lupus
Sure. Sure. Which
anticoagulant?
one?
The lupus anticoagulant, ma'am.
Sure.
You were asking why must it be considered? Now, to help you answer this, Sir Ken, I'll try. um,
Okay, sir. Thank you, sir.
Ma'am Joy, basically lupus anticoagulants, ma'am, are these are, if I recall, these are antibodies that are either IgG or IgM in class, and they would usually target the APTT reagent, specifically the phospholipoprotein component of the APTT reagent. Now, in if you have hemophilia, ma'am, usually you would have a prolonged APTT result. Now, one of the things you do if there is prolonged APTT, you perform what we call mixing studies. In mixing studies, you mix adsorbed plasma. Basically, if it gets corrected, the problem would be the factors. But if your APTT isn't corrected, it's still prolonged, ma'am. You have to now consider the lupus anticoagulant because this lupus anticoagulant isn't actually affecting the factors anymore, but they are affecting the reagent being used in the APTT test. So that's when you have to consider the lupus anticoagulant. So it's a matter of that it's targeting the reagent instead of the it's no longer a factor deficiency mo. Yun po.
This is only for purposes of in vitro laboratory diagnostic screening.
Yes, ma'am, for the lupus anticoagulant.
But the
Uh,
name, yeah, but the name lupus it's by itself has nothing to do with lupus erythematosus.
No, ma'am, it's not related po. If I recall. Yes po. It's more of a inhibitor talaga siya, ma'am, on the yun po.
So, lupus anticoagulant uh, is not specific for factor 8.
Uh, it usually targets APTT, ma'am. So since it's APTT, it usually involves the intrinsic pathway factors being tested, which are your factor 8, 9, 11, and 12. So those are the usually effective. So it could cause a problem when you run your APTT test for those factors, ma'am. Yung intrinsic pathway
So,
factors.
based on this premise, okay. So, the lupus anticoagulant, okay, is non-specific,
Yes, ma'am.
not specific,
It
right?
could be specific, ma'am, for intrinsic factors only. Sorry.
For intrinsic pathway factors.
For the APTT test, ma'am, specifically. For the factors, rather for the factors being tested by the APTT.
Right. With for APTT, these factors are intrinsic, right?
Yes, ma'am.
Okay.
Okay.
So
Sir
if
Kenneth.
Yes, ma'am.
All right. So points of clarification. Okay. So you have inherited and acquired type of hemophilia. Okay. So we need definite clarification whether it is only the acquired type that is autoimmune, or can we say that the inherited type is also autoimmune? And if yes, so if both are autoimmune conditions, okay, so we want to see the reactions between the antigen and the antibody. Okay, so a very simple illustration, okay, showing the autoantibodies formed, okay, because based on the treatment recommendations, okay, the treatment recommendations include, okay, uh, gene therapy that will promote immune tolerance. Okay? So immune tolerance, as defined earlier, will make the immune system unresponsive. Okay? So when the immune system is unresponsive, there is no antibody response, right? So you are suppressing, okay, the immune response of the patient. Okay? So we need some clarification with regards to the autoimmunity or autoimmune basis of this condition. Okay,
Okay, ma'am.
and why uh in your case presentation? Okay, so you have a 90-year-old patient. Can you show it to us? So after 5 days, then the patient went back.
Yes, because the recurrence of hematuria.
Right. So it was found out that upon returning after 5 days, and the assay was done again, there are factor 8 inhibitors were checked again and level 12. Okay, so it means to
Same
say
level.
that, yeah, so it means to say that even after treatment, right? So the patient still have circulating inhibitors of factor 8 based on the second bullet. Are what are the factors that lead to increases in F8 inhibitors? There's something going on, why the inhibitors are becoming increased even after the initial treatment was given to the patient. Bakit nandun pa din
Um,
siya even if after treatment? So can you uh, find it out, Sir Kenneth? Why are these inhibitors
Actually,
very difficult to?
okay, ma'am. I'll also include that in the next presentation.
Okay, also would be an interesting in terms of clinical correlation, right? So being medtechs, okay, for example, we're doing these assays in the lab, okay, and we also it's also very useful for us to check on the current medications being given to the patient, right? So we know that there are some medications that would interfere with the assay. Okay? Now, can you also find out whether patients that are being given antiplatelet drugs, okay, will interfere with the assay?
Okay, ma'am.
Antiplatelet drugs are being given. They are relatively common, actually, given to patients at risk for CVD diseases or disorders. So please also check, okay, if this could somehow, okay, affect the assay. And then emphasis on examples of inhibitors of factor 8 and 9. The immunologic basis, okay, so you were able to show the genetic basis of hemophilia A and B. So it's a very good illustration right there. So you have the most most of the time or all the time the females are carriers, and then the signs and symptoms will be passed on to the male offsprings. And then I saw one term that you used. Can you tell us what is lionization?
Lionization.
So it in one of your slides.
So actually, lionization, ma'am, it's the inactivation of the X chromosome. So this happens usually on females since they both have two X chromosomes. So one X chromosome becomes defective while the other one is still working.
So what does it have to do with hemophilia?
It has to do with hemophilia, especially if the female inherits the defective gene from the father. So patients with inactivated X chromosome who's female and and inherited the gene will those with Turner syndrome exhibits hemophilia.
Does that explain why daughters, okay, only serve as carriers?
Um, yes, ma'am.
One of the two X chromosomes is inactive, right? Okay, so for the daughter, so you have two XX, okay, and
Two XX.
one of these two is inactive. So that would probably explain why females only serve as carriers, or they are not carriers at all. unaffected. Okay. Do you have do we have any more question about any more from the audience? We want to hear your voice. Is there any report about the lifespan of hemophilia patients who are in the mild to moderate spectra of the disease?
Mm, I haven't gone into that. The only thing I haven't gone into that.
So you can just look it up. There are many publications anyway.
Mm, okay, ma'am.
So you just need to, I mean, for example, if you know a person who has hemophilia, it would be interesting to know the average lifespan of people with hemophilia. Of course, in the severe form, okay, chances are slim. Okay, but in the moderate or mild, okay, so with all the treatment options now available, okay, so probably there are already reports about life expectancy rates, okay, among these patients. And then you also very interesting. So there are local data. So you showed a census in the Philippines about hemophilia. So hemophilia A and B. Then you also have unknown type, right? So when was this? What year?
2020. So they compiled the data 2020 and they publicized it the next year. So most of the participant countries of this are only 120. That includes the Philippines as well.
So it would be interesting to know more about the Philippine data. So is there if there is any other local study about hemophilia? In St.
Okay,
Luke's
ma'am.
Medical Center, they have studies on hemophilia. So probably already published. You might want to check.
Okay, ma'am.
Then you share with the class the copy of the publication.
Mm, yes, ma'am.
Do you have any questions or Pax? Are you here? Were you able to listen to the presentation? We haven't heard much from the audience. Can you read the questions, Sir Kenneth? I think there
Oh,
was a question.
I
Okay, Sir Pax, you can
yeah.
just type your question. Are you here? How about our foreign students? Do you have any question? there is also a mention about hemophilia being idiopathic. Can you show it to us, Sir Kenneth? I
And
saw
you,
idiopathic, idiopathic cause.
um, for hemophilia B, ma'am. Mm,
The previous one, the other one. Okay. Acquired hemophilia A. Most cases are idiopathic
I think.
and acquired type uh, affects both male and female. For the inherited, either the females are carrier or remain unaffected, and then the males are the affected population. But for the acquired hemophilia A, AHA, most cases are idiopathic, affecting both male and female. All right. So I do not have any more questions, so we will wait for Sir Kenneth's responses to the questions 2 weeks from now. Right. So
Okay, ma'am.
next week will be your practical exam. All right. So do we have any more scheduled presenter for today? Yes, Ma'am Jem. Are you slated for today, Ma'am Jem?
Hello, Ma'am Joy.
Yes.
Can I just clarify po that there will be no presentations next week, that we will only have the exam.
Yes, only exam for next week.
Okay, thank you, ma'am.
All right. While waiting for Ma'am Jem, I will answer the question. Should Ning report on another specific example? Yes. Okay. He has to choose only one for hemolytic anemia. So there are many examples presented earlier. Okay. Just one, and then you focus on that particular example. Okay. Now I strongly recommend all of the presenters to provide also molecular basis. Okay, so genetic and molecular basis when applicable for the disorder being presented. Okay. We do not want the presentation to sound like a typical college reporting level of presentation. We want to add some more details that were not provided, okay, before when you were in your college. All right, so I hope we are clear on that. Mom Jem, are you ready?
Yes, ma'am.
All right, so can we have a 5 minute break before you present? Time check is 9:41. Short break, 5 minutes. Right, we can start, Mom Jem.
Good morning, Ma'am Joy, and good morning, classmates. My report today is about the Bernard-Sunder syndrome. Our objectives in this report is to review the history and the discovery of the disease, to explain the etiology, physical presentation, and pathophysiology of the disease, and to outline the treatment and management options for the disease. So in 1948, two hematologists named John Bernard and John Persoler discovered the disease when a male patient presented episodes of severe abnormal bleeding. The male patient had prolonged bleeding time and low platelet count with very large platelets or macrothrombocytopenia. The male patient had an older sister that also had hemorrhage to death, and since then, similar disorders have been described in large numbers of individuals, always transmitted in an autosomal recessive manner. They have named the disease before as the hemorrhagic thrombocytic dystrophy. Bernard-Suller syndrome is a rare hereditary blood clotting disorder that hinders the ability of platelets to stick together and spread around the blood vessels. Patients with this disease have insufficient number of platelets and they appear to be larger than normal. The effect is restricted to the megakaryocyte platelet lineage, and this disease involves a defect of the GP1B 9-5 complex, which is an essential platelet receptor complex that principally binds the von Willebrand factor. The von Willebrand factor functions as a bridging molecule at the sites of vascular injury for normal platelet adhesion and promotes platelet aggregation. Majority of these mutations inherited in an autosomal recessive pattern, so it is prevalent in both male and female. The typical presentation of Bernard-Suller syndrome starts at birth and continues throughout life, and it is characterized by bleeding from different sites, hemorrhage post-trauma, and heavy menstrual bleeding in females. The prevalence of the disease is estimated to be 1 per million. Severity is variable, ranging from mild to severe in cases of surgery and severe injury. And with age, bleeding may start during infancy and may continue through adulthood depending on the severity. However, due to under-recognition and misdiagnosis, the prevalence may be higher than estimated. The primary deficiency of this disease is the lack of or reduced expression of the P1B95 complex, which is mainly found on the platelet surface. This complex is important in adhesion receptor, and this complex consists of two molecules each of GP1B alpha, GP1B beta, and GP9, while it has one molecule of GP5. Uh, in regards to this mechanism, there are three genes involved in the mutations, which is the first three, the GP1B alpha, GP1B beta, and the GP9. I have mentioned that the important function also of this complex is to bind to von Willebrand factor and initiate a signaling cascade that would activate the platelet integrin, which leads to platelet aggregation. This also plays a role in maintaining platelet shape by linking platelet surface to submembranous network of actin filaments, the platelet skeleton. Considering the functions of this complex, it is also expected that mutations in the encoding genes could lead to reduced activation of platelets, defective adhesion, and inadequate clot forming capability. The defective or absence of platelet aggregation is confirmed when exposed to ristocetin. Ristocetin is an antibiotic that causes the platelets to aggregate. The common symptoms of this disease are cutaneous hemorrhages such as purpura and bruises, epistaxis, gingival bleeding, menorrhagia, heavy or prolonged bleeding, and presence of blood in stool. Rare symptoms are gastrointestinal bleeding and hematuria. For the diagnosis, a complete blood count with smear usually the physician requests. A mild to moderate thrombocytopenia with giant platelets. Also, a prolonged bleeding time. For the platelet aggregation studies, histocity-induced aggregation is absent. Aggregation response is normal with others such as epinephrine, arachidonic acid, ADP, and collagen. And for the platelet function assay, it measures both platelet adhesion and aggregation, time evaluation of high shear whole blood flow blocked by platelet plug into a hole in activated surface. The PF100 is raised. These tests may be useful but with variable sensitivity depending on the severity of their defect. Flow cytometry, this is used for confirmation in defects in the GP1B95 complex by antibodies directed against platelet surface antigen CD42B, revealing a severe reduction or deficiency of GP1B. Other platelet antigens such as CD41 and CD61 are normal. For the treatment, uh, patients diagnosed with this disease should be well educated about risks of bleeding, avoidance high risk sports that might lead to bleeding, and patients can also suffer from iron deficiency due to excessive bleeding and should be monitored closely and supplemented with iron if needed. For the bleeding episodes, platelet transfusions are recommended as well as antifibrinolytic therapy and desmopressin acetate. Uh, Usually, the platelet transfusion is the first line of treatment in patients with Bernard-Sutter syndrome, and antifibrinolytic agents are drugs that delay the breakdown of blood clots such as trexenamic acid. Tranexamic acid has been used successfully in management of mucocutaneous bleeding, but this drug should be avoided in patients with pulmonary hemorrhage or those with active hematuria due to risk of formation of intraluminal clots that can lead to respiratory and renal failure. For the desmopressin acetate, it is a drug used to control the amount of urine your kidney makes for people with diabetes insipidus, but it also shown to shorten bleeding time in some patients with Bernard-Sutter. It can be used for minor bleeding episodes. For the differential diagnosis, there are two other platelet disorders that may look like Bernard Soulier but is different in other other form. The Meheglin anomaly, which is an inherited giant platelet disorder with the same manifestations like the Bernard Soulier, but with other clinical findings such as nephritis, paraplegia, and pituitary growth hormone deficiency. It is normal in aggregation studies, and peripheral smear evaluation shows large platelets and dull bodies. Uh, the dull bodies is present inside the neutrophil and the platelets is kind of large. For the platelet syndrome, it is also an inherited giant platelet disorder. Platelet aggregation shows reduced response to collagen and thrombin, but normal responses to adenosine diphosphate and arachidonic acid. For the ristositine, reduced or normal uh, response. Platelets appear to be gray-blue on right gym sustain. That's why it is called blue platelet syndrome. That's all my report.
Audience, please ask questions. Sir Alex first.
Regarding the most patients, you mentioned in your slide that most patients experience iron deficiency. I'm just curious if this might lead to other diseases such as the case with iron deficiency anemia, and also is uh, Bernard Soulier perhaps maybe a risk factor for iron deficiency anemia. Thank you po.
Yes, sir. It can be a risk factor since uh, it, the patient can bleed a lot. But for the Bernard Soulier, the patients are what is the term? The patients are monitored closely naman po. And iron deficiency, they can be supplemented with iron, and usually the physicians are educating the patients about the risk on how to avoid excessive bleeding and not lead to other um, deficiencies such as lack of iron.
Thank you. Thank you.
Next question, Sir Jim.
Good morning, Ma'am Jem. I just want to ask regarding the ristositine. Why is Bernard Solier does not respond to ristositine, or it does not induce platelet aggregation? What's so special or different with ristositine that is not present in the other compounds that you mentioned, like the ADP, the arachidonic acid, and the others? Thank you.
As I have read, Sir Jem, the ristositine is like it is a confirmatory test with the Bernard Soulier together with the flow cytometry, because the ristositine levels po that the ristositine only aggregates platelets in the presence of plasma. When in wait, how can I explain this? Wait, so the ristositine, upon addition of the sample in patient with a Bernard Soulier syndrome, it will not clot. But with other platelet disease such as von Willebrand, it can using the patient's plasma and freshly washed platelets, it will reduce it. Wait, I'm sorry.
Sir Peter, you're asking.
Yes, good morning, Ma'am Jem. Ma'am Jem, do you still remember the three functions of the platelets, the adhesion, activation, and aggregation? My question is, which activation or which function of the platelet is affected in your Bernard-Soulier syndrome? Is it adhesion, activation, or aggregation?
Do you have some audio problem, Ma'am Jem?
May nagpupukpuk ata sa kanila mo.
Okay lang. Ganun talaga. Happens. Especially every
Sorry po.
Saturday.
The
Okay lang, Ma'am Jem. We
neighborhood is
understand. No problem.
mostly on the aggregation, Sir Peter, since the GP1B9 complex uh, in in connection with the von Willebrand factor initiates platelet aggregation.
Okay, ma'am. Thank you.
I'm taking note of all those who are actively participating in the Q&A portion of the presentation. So did you mention about HLA matching as HLA typing, Ma'am Jem?
No, ma'am.
Was it mentioned about one of the treatment options for the patient is to do uh, platelet transfusion? I think
Yes,
there's a
ma'am. The
slide.
platelet transfusion po.
Okay. So in this context, okay, so even if the defect in the syndrome is more on qualitative, right, Jem?
Yes, ma'am.
So qualitative because of problems with platelet aggregation, okay? But quantitatively speaking, okay, so what's the platelet count for the patient? Is it increase, decrease?
Decreased po in patients with Bernard
By
Soler.
how much?
From
Um,
20,000 po to near normal.
so as low as 20,000
Yes, ma'am.
platelets, and
Yes,
in
ma'am.
some cases can be normal.
Yes po, if not, if depending on the severity naman po, if it is only mild, it can be normal but with giant platelets po.
Right. So, platelet transfusions, okay, as one of the treatment options during bleeding episodes, okay, uh, are platelet transfusions only indicated for severe forms, or as long as the patient exhibits bleeding episode?
For severe bleeding episodes po, because we have other treatments such as this antifibrinolytic therapy po, or usually outpatients.
And then how do you monitor patient status during treatment? Are there any laboratory tests that can be performed to monitor treatment response?
Yes, ma'am. We have the bleeding time po, platelet aggregation studies, and the platelet function assay. But the platelet function assay is not as sensitive as the other tests like the aggregation test po.
And then in the screening, so if the patient presents with bleeding tendencies, right? So you mentioned about other platelet disorders, okay, that could be mistaken as BSS, okay. So initially when the patient consults, okay, so can you reiterate the basic test? So you have CBC, what else? Screening test.
CBC po, bleeding time, the platelet aggregation studies, and the platelet function assay. The difference po between the other platelet disorders, for the smear, we only have giant platelets po in the Bernard Soulier, but for the Mayheglin, um, it shows large platelets and dull bodies inside the neutrophils. And for the gray platelet plasma, obviously the gray platelet in the right gene sustain. For the bleeding time, um, for the bleeding time, they are all uh, elevated, but for the platelet aggregation studies po, this is specific to Bernard Soulier that it the aggregation is absent during ristocetin induced aggregation.
So would you say that other coagulation studies may be of no value when diagnosing the syndrome? Like for example, it is not recommended to perform any more PT and PTT because
Ye-
these are not anymore
yes, ma'am.
practical. They're
It is not recommended to perform PPPTT because the problem here is in the primary uh, function of the platelet, which is the aggregation po and
now for the
have other
smear. So you
factors.
mentioned about the CBC and then you have the smear. Can you go back? All right. So you have the CBC with the PBS, okay, so mild to moderate thrombocytopenia, and then presence of giant platelets. Now, should the giant platelets be estimated? Like, for example, is there a a range or a count how many giant platelets will you encounter in the smear reading? In the other disorders similar to the syndrome, to the BSS syndrome, they also have giant platelets plus other okay, smear findings. But in this particular disease, okay, so the emphasis was put on giant platelets. Okay, so is there any particular count or range to take note of when you do the smear examination and you find giant platelets? Like how many in the smear?
Um,
The audience
I
can also share if they have any information.
there are no like panel po or
Count,
count
count or range.
from.
Isn't it that when we do our platelet smear exam, we also quantify? We do approximate counting in 10 fields, for example. Is there a specific finding as to the approximation in the smear?
I tried to find it, ma'am, but there are no like guidelines po on the count as long as the giant platelets are present and the platelet counts ranges from 20,000 up to 150,000.
There's a comment from Sir Peter. Reference used.
Ma'am Joy, the references I used were from the compiled notes in my college days, which were given to me by our dean CEO.
So, in the other disorders with also giant platelets, the same. Only the appearance of a single giant platelet plus the other um, cells, abnormal cells, will lead to the diagnosis of these other disorders. But here, for Bernard-Soulier syndrome, the mere presence of one giant platelet will suffice a high index of suspicion.
Yes, ma'am. And then you should correlate it with your clotting time and bleeding time because Bernard Soulier, ma'am, is a problem with your primary hemostasis. So when you say primary hemostasis, it usually involves the platelet function, while for secondary hemostasis, it involves the clotting factor. So basically, as mentioned by Ma'am Jem, in a Bernard Soulier syndrome, the problem is all about the primary hemostasis, basically all about platelet function. So one of the best tests for platelet function, even if it is considered old test, is your clotting time or bleeding time.
So how about the next slide, Ma'am Jem? Right? So you have platelet function assay. Okay, so this is no longer a routine test. Okay. And then for the platelet function assay, it measures, okay, still part of the primary hemostasis. So you have adhesion and aggregation. Okay, so these two tests will only be performed whenever there is a finding in the CBC with the smear examination. Okay. Now, you mentioned about some mutations. Can you show us the slide about the mutations? So this is a rare inherited disorder. So there are some mutations of the genes involved. Can you show to us the slide?
On this slide now.
Okay, so mainly the disorder is caused by a qualitative defect of this glycoporin 1b 910 95 complex. Okay, so can you tell us if this GP1b95 complex is it a structural protein defect? Is it a membrane defect, or does it have to do with a receptor defect?
Hello, ma'am. It is a receptor defect, ma'am, since it cannot bind to von Willebrand factor, uh, and it results to dysfunctional receptor, resulting in defective addition to cell endothelium.
There is a problem with the receptor.
Yes, ma'am.
So receptor region. Okay, so it will not, or it fails to bind with your VWF. Okay, so there is no, or there is an impeded, okay, signaling cascade. So in ultimately it leads to failure of the platelets to aggregate. So is there any information as to why the platelets become large? Is there a problem with the maturity and development also of the platelets? That's why they maintain a large size when they should have been smaller under normal conditions.
Um, the the GP1B 95 complex also has a role in maintaining platelets shapes the plate uh, since it has a mutation or lack in this complex, the platelet will tend to be the platelet shape will that we maintain, and it's a little larger than usual.
You have a slide showing the lineage. Can you go back to the slide?
Mom, I don't have slide showing the lineage. I only have this.
Just I think that's just one bullet, not a picture, just one sentence.
This one, this also plays a role in maintaining privilege.
Parang hindi siya. Can you browse mga ulit siya?
This one, Mom.
There, that one. The defect is restricted to the megakaryocyte platelet lineage. Now, earlier, we are talking about the role of the structural protein GP1B95 complex, which not only maintains the shape of the platelet, okay, but it also has a receptor. It serves as receptor for your VWF, right? But here in this particular side, there is mention about the lineage of the megakaryocyte platelet. Okay, so do you think that the defect in the lineage somehow or is associated with the size of the platelets produced in the syndrome? It appears that
Yes, Mom.
there is some problem also with the series, with the megakaryocytic series, such that the platelets, okay, will have larger than normal appearance of their platelets. What's your comment on this?
Um, Maybe the platelet did not mature uh, and stayed in this type of lineage, so it's a little bit larger than usual.
So can you find out the what particular portion of the platelet series is the problem coming in so that these
I will
platelets
have
which
to
should
check.
have been okay, which
Sorry,
should
sir.
have been smaller in size, okay, they do not develop into the smaller size. Instead, they appear giant. So there should be a part of the lineage involved. So the mutation could have taken place somewhere in the series. So is there some compensatory mechanism involved? Is the bone marrow also compensating? Okay, so please also check, Ma'am Jem, if the bone marrow is also involved in some kind of compensatory mechanism owing to the defect in the platelet, qualitative platelet defect. Is the bone marrow triggered? Yes or no?
Ma'am, in one of my sources, I have read that I just did not include it, but in the diagnosis, uh, some physicians require for a um, bone marrow. Wait, I have to read again. Bone marrow biopsy, but normal numbers of megakaryocytes are seen without morphologic abnormalities. That's why I just did not include.
So please include it also in your slide, ma'am,
Okay, ma'am,
just
noted
so
po.
we can see the continuity. Okay. So insert it uh, into the slide about the lineage. Okay, megakaryocyte platelet lineage. Okay, you see, physiologically, if something wrong with our bodies, the certain compensation, okay, or adaptive mechanisms, okay, become triggered. So it's like either it's a positive effect or it's a negative effect. So it's a normal response of the body under physiological conditions when something is wrong. Okay, so it will attempt to correct. Okay, so we need to find out in this particular syndrome. So please include also an illustration about the binding of the GP1B95 complex with the VWF. Okay, so it is also actually a cascade of signaling events. Okay, wherein if some portion, okay, of the interaction becomes interrupted, okay, so the defect will become apparent. Okay. Okay, so I hope that answers your question, Ma'am Evere. What is the worldwide incidence of the disease?
One in one check. Ayan. Estimated to be 1 per million.
Okay. And then there was a slide showing about the CD, clusters of differentiation. Can you go back?
What slide was it, ma'am?
About clusters of differentiation. I think it's on the, you try to go to diagnosis or
This one.
next next one. Look at next one.
Ah,
There,
this one, ma'am.
diagnosis. Clusters, okay, the flow side. Okay. So flow cytometry is it the confirmatory test or
Yes,
procedure?
ma'am, together with the platelet aggregation.
Makes it complicated, your presentation. Here is the mention of antibodies again. Okay. So these are the facts that we are able to gather from that the syndrome is an inherited rare disorder. So there is a defect or mutation in the gene that codes for the GP1B95 complex. Okay, in effect, there is some problem with the reception or receptor site for the VWF. Okay, the same GP molecule is responsible for maintaining the shape. Okay, and also there is a problem with the lineage in the platelet. Okay, so those are very important pieces of information. Okay. And then here we also find that one of the confirmatory test procedures would be flow cytometry. Okay. So in flow cy, so there is mention here about measurement of antibodies against platelet surface antigen, CD42B. Okay. And then you have CD41, CD61. Okay. So can we hear more information about this next time, Ma'am Jem?
Noted, ma'am.
So it's becoming more complicated, right? So this time antibodies are already involved. There is also mention about PSA or platelet surface antigen, and then mention about the CD antigen. Okay, so please provide some more information about antibodies against these surface antigens, Ma'am Jem, and how they are related to the syndrome. Okay, so our primary understanding is about the mutational defect, and then this one is another different explanation. Okay,
Noted, ma'am.
okay, so next week na lang, Ma'am Jem. Okay, do we have any more questions from the audience? Okay, so we have very good topics for today. Okay, these are very important to emphasize, okay, and understand more than just the tip of the iceberg. Okay, so also stating that there are advances, okay, in terms of diagnostic platforms being used for hematological disorders, the same as all the other presenters, okay, prior to this. So there are already genetic basis, molecular basis, so not just at the cellular level. Okay, so we will wait for your responses by next week, Ma'am Jen. No more,
Noted, ma'am
no
Jem.
more questions. All right. So announcement for next week. So we will not meet um, here in GMU, but you will receive an email link for the practical exam. Okay. Again, the scope of the practical exam will be about the normal cellular morphology. Okay. The white blood cell malignancies will not be included. Okay. So doon muna tayo, normal morphology, and then cell inclusions. And please review analysis and interpretation of histogram and scattergram. Now, these two are visual representations of cell populations, distribution, using automated hematology analyzer. Okay. Any clarification about the exam for next week? So it should be easy. No question about the exam. Yes, Sir Jem.
Ma'am, is the like the RBC, the various RBC shapes included, like the codocytes, the schistocytes, echinocytes, are those included po, ma'am,
Not
or
yet.
not
Only
yet?
the normal morphology, but I will include the inclusions.
Okay. Thank you,
Cytoplasmic
ma'am.
inclusions. Yun lang muna. We do not want to make it a bit difficult. Okay, so since the exam is only online, so we will
Okay.
divide the practical examinations into maybe two or three parts. Okay, so no leukemias, no malignancies. Okay? Because there are normal physiologic alterations, right? Meron pa rin namang normal physiologic alterations in the form of inclusions. Okay, so meron pa rin siya. But the abnormal cells, okay, malignant cells will not be included. Nahirapan kasi kayo mag-identify. Right, Sir Jem?
Ma'am,
Again?
how about ma'am the progenitor cells po? Like the immature cells, ganyan. Are those included po?
The series?
Yes, ma'am. The
Yes, yes.
pro. Okay,
For
thank you po,
example, you
ma'am.
have the orthochromatophilic, you have the metamyelocyte. These are still normal, right? These are still part of the lineage of the series. Kasama yun. It is not limited to the peripheral circulation, but the bone marrow, okay, those cells that are part of the bone marrow, normal bone marrow, will be included. And then some side questions, maybe one or two side questions for each picture. Please send your presentations to my email and share to your classmates as well.
Ma'am, one last
Yes,
question
sir.
po. I'm sorry. Ma'am, is the practicals timed examination, or like we are free to pass it on a specific time, or are there any
Ah,
restrictions for the
so next
time?
week
For,
between 8 a.m. to 11 during
thank you, ma'am.
our class hours. Okay.
Thank you po.
So you have 3 hours to finish the exam. Right? So if there are no more questions, I will dismiss you now. I really hope one of these days we will meet in person. I don't know how would that be possible. I don't know where